we start a new system today. That is, which system is this? Respiratory. So you're going to have your exam till respiratory system. I've given you the syllabus. Porikha up to respiratory system thakbe. Okay. So all these topics included, whatever will be taught in respiratory system up to respiratory system, any questions can come from that. Okay. So be aware of it. So I'm not going into the details of lungs and all, because you know, expected, you have studied anatomy. I'm not getting into the details of anything. So I'll straight jump, because we are running short of time. I'm going to straight jump into the topic for today, pneumonia. So what is pneumonia? What's your concept of pneumonia? অল্প ঠান্ডা লেগেছে লোকে বলে pneumonia হয়ে গেছে, right? Unjudiciously people say pneumonia হয়ে গেছে. So each and every layman knows that there's something called pneumonia. So you, being medical graduates, you're going to be graduated very soon. What's your concept of pneumonia? First and foremost thing is, what is it? Okay, ঠিক আছে. Lower respiratory and upper respiratory, which is more common actually? Upper respiratory tract. URTIs, upper respiratory tract infections are more common. For example, common cold, flu, etc., etc. But we are not dealing with that. We'll be dealing with pneumonia, which is actually a lower respiratory tract infection. It can follow a URTI, but pneumonia is a LRTI, lower respiratory tract infection. So what is pneumonia? Ekdom basic medical terms hai, what is pneumonia? Huh? Consolidation of lungs, se to histological findings ba gross findings e asche. Tar age ekdom basic layman's term hai, inflammation of the lung parenchyma. Okay, so pneumonia is nothing but, am I audible? Last day. Am I audible? So it's inflammation of the lung parenchyma, which can be caused by, so inflammation of the lung parenchyma, which can be caused by bacteria, viruses. URTIs are mostly caused by viruses. Mone rakhbe. But LRTIs jokhon asche, lower respiratory tract infections, for example, pneumonia, viruses play a major role. Bacteria play a major role. So it can be caused by predominantly bacteria, sometimes virus, mycoplasmal or fungal infections. These are organisms. Other than that, you have something called aspiration pneumonia. Heard of an aspiration pneumonia? Have you heard of an aspiration pneumonia? আমি একটু পরে বলে দিচ্ছি একটু ছোট করে. Aspiration pneumonia is something when the person inhales fluid or vomitus or whatever it may be, some chemicals which goes into the lung and causes pneumonia. So pneumonia is basically inflammation of the lung parenchyma. Okay, inflammation of the lung parenchyma. And last je line ta ache, impairment of local host defense or systemic resistance of host. I'm coming to that when I'm talking about the mechanism. Okay. So what are the predisposing factors? What are the predisposing factors? Pneumonia kader moddhe hote pare? What can cause pneumonia? One is various chronic diseases. I'll be coming to that. Immunologic deficiency, immunosuppressive agents, or leukopenia. Mane conditions which impair, these are basically conditions which impair what? Your immune system. These are conditions, very common. These are conditions which impair your immune system. For example, chronic debilitating diseases, immunological deficiencies, immunosuppressive agents, and leukopenia. Okay. Why leukopenia? What does leukopenia has to do with pneumonia? Leukopenia te ki hocche? WBC count kome jacche. So WBCs are the what? They are the agents which act as the first line of defense, right? So jodi leukopenia hoye thake, it can lead to immunosuppression. Okay. So what are the various sources of infection? Question korte pare examiner, what are the various sources of infection? Pneumonia ta kibhabe asতে পারে? So যদি source আছে, don't straight away jump to bacteria, virus, not like that. One is community acquired. One is community acquired, which is the most common. Mostly associated with what? The microorganisms. Mostly associated with the microorganisms. Community acquired, bacteria, virus, fungus, etc., etc. That is from the community. Number two is, what is number two? Hospital acquired. Microbiology te hoye geche egulo. So tell me, what is hospital acquired? Which is the most common? Ventilator, respirator associated. Which organism? Pseudomonas aeruginosa. Pseudomonas aeruginosa. So hospital especially occurs in chronic debilitating diseases or persons with immunodeficiency. Maybe within 24 to 48 hours after admission into the hospital, these patients develop pneumonia acquired from the hospital. The most common source is the respirator or the ventilators. Right? The most common source is respirator or ventilator, and which organism is predominantly involved? P. aeruginosa, Pseudomonas aeruginosa. Okay? Other than that, কি করাতে পারে? E. coli, Staphylococcus aureus, Klebsiella, they can also do. So they secrete an endotoxin. The organism gulo is, this bacteria secrete an endotoxin which are responsible for the pathogenesis. Clear? And the third one is aspiration pneumonia. Aspiration pneumonia কার মধ্যে হতে পারে? Huh? Bedridden patients means what? সব bedridden patients তো হবে না. Patients in, yes, you said something, where there is a suppression of the cough reflex. আসছি ওটা আমি আসছি mechanism-এ, suppression, predominantly suppression of the cough reflex যে patients এর মধ্যে থাকে. For example, patients with coma, dementia, Parkinson's disease. এদের না একটা অনেক কজ আছে. These are a few examples. Suppression of the cough reflex হয়, and they aspirate the, say, vomitus or contents of the stomach. ওটা না aspirate করে they go into the mediastinal shift. অত জানি না ভাই. Good, দেখা যাবে কি what is mediastinal shift to do with pneumonia. Okay, so aspiration, the contents are aspirated into the lungs, and these patients develop something called aspiration pneumonia. Okay, is it clear? Should I repeat? So what is a community acquired? So if someone asks you what are the sources of infection, please say, don't just straight away jump into the causes. First divide them into these three headings. One, most common, is from the community. Community mane ki, I did not explain. Number two is hospital. So hospital most common source is the respirator or the ventilator, and the organism which is most commonly associated is Pseudomonas aeruginosa. And the third one, not very common, but it does happen, so you need to remember, is an aspiration pneumonia. Aspiration ki kore hocche? Patients who have suppressed cough reflexes, pharyngeal reflexes are gone basically. For example, patients of coma, with dementia, Parkinson's disease, etc., etc. These patients, they aspirate the vomitus or various chemicals or contents of the stomach into the lung, and it can actually be fatal. It can actually be deadly, fatal. Okay, so these are the three sources of infection. One is from the community, number two is from the hospital, and number three, are least common of the three, is via aspiration of the contents, gastric contents or whatever it may be, into the lungs. Okay. So pneumonia is nothing but a state of jeopardy. You know what is jeopardy? What is jeopardy? I'm not explaining that. So pneumonia is nothing but a state of jeopardy. So what is jeopardized? Your system is jeopardized. Your system is jeopardized, your system is in a state of jeopardy. Okay, so first and foremost thing hoche loss or suppression of the cough reflex, which is just explained. For example, patients in coma, anesthesia, neuromuscular disorders, etc., etc., dementia, okay, Parkinson's, etc., etc. Number two is, now what is number two? Injury to the mucociliary apparatus. What is the role of mucociliary apparatus? What does cilia do? Pseudo-stratified ciliated columnar epithelium kothay thake? Respiratory tract e thake. What is that ciliar function ta ki? Cilia basically, one person at a time, one person at a time. Cilia, what does cilia do? One word answer. Clearance to অনেকগুলো word হয়ে গেল, just one word answer. বাড়িতে আমরা জল কি থেকে ইয়ে করি? হ্যাঁ? Filter. Filter, that's the word I'm looking for. Filter. So filter out all the unwanted substances. So if the mucociliary apparatus is jeopardized or it has been injured or it has been impaired. Okay, so what are the causes? Any kind of injury. One of the most important cause for destruction or impairment of the mucociliary apparatus is what? Very common, come on. Smoking. Smoking is one of the most important causes. Other than that, অনেক কিছু হতে পারে, ingestion of hot or corrosive substances, genetic diseases, etc., etc. So impairment of mucociliary apparatus কোথায় হতে পারে? The most important cause is, before going to ingestion of corrosive and hot substances, no, first and foremost thing is smoking. It can be a first-hand smoking. First-hand smoking, you know what is a first-hand smoking? আমি যখন Tuesday আমি bronchogenic carcinoma নেব, I'll explain. First-hand smoking, it's quite known to everyone, cigarette smoking or whatever it may be. And there is something called second-hand smoking. Someone smoking in front of you and you inhale that smoke, and even if no one's smoking, we live in a place which is full of pollution, which is full of pollutants. So you inhale the pollutants. So those are all second-hand smoking. So this all can destroy or impair the normal function of the mucociliary apparatus, causing its destruction. Other than smoke, you have ingestion of hot and corrosive substances. Not very common, but it can happen. There can be certain genetic deficiencies which can give rise to, which can impair the cilia. Okay. Number three is accumulation of secretions. Number three is accumulation of secretions. For example, there's a disease called cystic fibrosis. You get multiple cysts in the lungs, pancreas, etc., etc. In various organs, you get multiple cysts. There's something called cystic fibrosis. Yete porecho genetic and pediatric diseases er moddhe cystic fibrosis chilo. Just go through it. I'm not explaining cystic fibrosis. So there will be accumulation of secretions. Interference with phagocytic or bactericidal activity of the macrophages. Interference with the phagocytic or bactericidal activity of the alveolar macrophages. Okay? মানে macrophages fail to function. So, তাহলে কি হবে? There won't be any phagocytosis. So the organism which has entered your respiratory tract will not be phagocytosed, will not be opsonized. Henceforth, it will not be killed. So it can flare up. And number 5 is pulmonary congestion and edema. Pulmonary congestion and edema, there can be various causes like cyanotic heart disease and all. So pulmonary congestion and edema. So these are the 5 mechanisms which can give rise to pneumonia. Starts with loss or suppression of the cough reflex. Number 2 is injury to the mucociliary apparatus. Then number 3 is accumulation of secretions. Then interference with phagocytic or bactericidal activity of alveolar macrophages. And the last one is pulmonary congestion and edema. So you need to remember these 5 causes. These 5 causes are predominantly the ones which jeopardize your respiratory system, and they can not only pneumonia, they can give rise to various other diseases of the respiratory tract also. But since we are studying pneumonia, I am concentrating on pneumonia, and these are the causes which can actually jeopardize your respiratory tract. Is it clear? Is that clear? Okay. So coming to the classification, we have 2 classifications. One is the etiological classification. One is the etiological classification, and the number 2 is morphological classification, means anatomical classification. Okay. Etiological classification means involving the microorganisms, and anatomical classification, that's which lobes of the lungs are involved, or which parts of the lungs are involved. Okay, the anatomy. Clear? So this is a big one. You did not remember, and pathology theke microbiology will teach you far better than pathology about the microorganisms. So I'm not asking you to remember each and every cause, but I'm giving you the important bacteria and how they cause pneumonia. Okay. So at least know the bacteria first, because LRTIs are predominantly caused by bacteria. So one is Streptococcus pneumoniae. You know all these organisms, right? I hope micro te hoye geche. I'm pretty sure. It's not I hope, I'm pretty sure it's over. So Streptococcus pneumoniae. So Streptococcus pneumoniae ki korte pare? How does it cause pneumonia? What are its characteristics? Come on, tell me. এর ক্যাপসুলটা কি করে? The capsule prevents phagocytosis. That is one thing. Its capsule prevents phagocytosis. And number 2, it produces copioid mucoid secretion. It produces copious mucoid secretion, which is responsible for all the secretions in pneumonia, right? Then comes Staphylococcus pneumoniae. Staphylococcus pneumoniae are predominantly seen in where IV drug abusers with bacterial endocarditis, intravenous drug abusers with bacterial endocarditis. ঠিক আছে? তো এটা কি করে? It causes lung abscess and pneumonia. So what is an abscess? What is an abscess? Suppurative destruction of the lung parenchyma, suppurative necrotic destruction of the lung parenchyma. So that is, there is a suppuration. So that is an abscess. It causes abscess and empyema. What is empyema? What is empyema? Not emphysema, it's empyema. There's a difference between emphysema and empyema. So what is empyema? Localized collection of pus. Localized collection of pus is called an empyema. And hematogenous dissemination occurs to distant sites. Hematogenous dissemination can occur to distant sites. Number 3, Klebsiella pneumoniae. Klebsiella pneumoniae. Streptococcus pneumoniae is over. Staphylococcus pneumoniae is over. Next comes Klebsiella pneumoniae. So Klebsiella pneumoniae ki kore? It produces viscid capsular polysaccharide. It produces a viscid capsular polysaccharide that is responsible for the thick gelatinous sputum. Pneumonia te sputum bero jano to, rusty sputum. So this Klebsiella pneumoniae produces the thick, it has a capsular polysaccharide that is responsible for the thick gelatinous sputum. Klebsiella pneumoniae. Number 4, Pseudomonas aeruginosa. Pseudomonas aeruginosa kothay? Hospital acquired er moddhe pore, hospital acquired infection e. They have a propensity to invade the blood vessels. Remember, why Pseudomonas aeruginosas are so dangerous? Why hospital acquired pneumonias are so dangerous is because of this particular characteristic. The Pseudomonas aeruginosa has this propensity to invade the blood vessels, and once it invades the blood vessels, it can disseminate to various organs. It can disseminate to various organs and the outcome can be fatal. The outcome can be fatal. So this is one reason, and they are seen in chronic debilitated persons with severe immunosuppression, hospital acquired. Just I have explained within 24 to 48 hours of admission into the hospital, these patients develop this pneumonia, hospital acquired pneumonia. The most common causes, the most common source is respirator or ventilator, and the most common organism is Pseudomonas aeruginosa. And why it is so fatal, why it is so deadly, is because of the propensity, this particular propensity of Pseudomonas aeruginosa to invade the blood vessels. So once it invades the blood vessels, it can disseminate to various organs. So the outcome is fatal. The outcome can be deadly. Okay, first and foremost thing is, they are patients with immunosuppression, and tar upore ki hocche, on top of that you have this microorganism disseminating to various sites. Okay, so it's a synergistic effect which has a profound ill effect on the health of the patient. Okay, got my point? And number 5 is Haemophilus influenzae. It also prevents, the capsule prevents opsonization and phagocytosis. So onek bacteria ache, echara then there are various viruses which causes, for example, adenovirus, RSV, etc. Then you have various histoplasmosis, toxoplasmosis, histoplasmosis, blastomycosis, coccidiomycosis, etc. Various fungus which causes pneumonia. But concentrate more on the bacteria, and of this bacteria, at least, obviously microbiology has taught you, your knowledge would be more than mine regarding the bacteria at least. But from pathological standpoint, if you write this bacteria, Streptococcus pneumoniae, Staphylococcus pneumoniae, Klebsiella pneumoniae, Haemophilus influenzae, Pseudomonas aeruginosa, and the mechanism, some of them prevents phagocytosis, and the capsule prevents phagocytosis. Some of them produce thick gelatinous sputum or copious mucoid secretion, which is responsible for the pneumonia. At least know the mechanisms. And Pseudomonas aeruginosa, it has the propensity to invade the blood vessels, so outcome can be fatal in patients. So at least remember these points. It will become easier for you. And when you, if this question comes, which is rare, I'll be honest with you, this question is very rare. But if it comes, at least for your knowledge point of view, from your standpoint, if you write this way in a tabular format, it will be better for examiners to check. So that way you get those extra brownie points. So coming to pneumonia, the anatomical location, morphology. Tinte ache, ami duto explain korchi. One is lobar pneumonia, number 2 is lobular bronchopneumonia, and number 3 is interstitial pneumonia. So lobar pneumonia means what? Lobar pneumonia means consolidation of a large portion of a lobe or the entire lobe. I'll show you the picture. Consolidation of a large portion of the lobe or entire lobe. Whereas bronchopneumonia ki? Patchy consolidation, not the entire lobe, but patchy focal distribution. And interstitial pneumonia is the alveoli are not involved, but instead the neutrophilic infiltrates are predominantly seen in the interstitial tissue. That is interstitial pneumonia. So we will be concentrating more on the first one, the lobar pneumonia, Okay, so let me show you the pictures. So obviously you can make out bronchopneumonia and lobar pneumonia. So what is lobar pneumonia? What I just explained involves the entire lobe. Okay. See, there is diffuse involvement. This is the healthy portion and this is the unhealthy portion, the involved lobes. Clear? There is diffuse involvement of the entire lobe. Hanana? Yes or no? Versus bronchopneumonia. In bronchopneumonia, the entire lobe is not involved. Rather, there is patchy involvement. There is patchy involvement. A patchy involvement আর কোথায় পড়েছো তোমরা? Let's see if you, I think, no, I haven't taken that class. আমি ফার্স্ট ব্যাচে এটা নিয়েছিলাম, তোমাদের ইমিডিয়েট সিনিয়র আর তোমাদের ব্যাচে আমি নিইনি। কোথায় পড়েছো প্যাচি ইনভলভমেন্ট বলো তো? GI tract এ কোথায়? Patchy involvement. IBD কোথায়? IBD Crohn's এ patchy আছে। anyway it has got nothing to do with it, just দেখাচ্ছি আমি একটা এক্সাম্পল দিলাম। So in lobar pneumonia you get diffuse involvement of the entire lobe, and in bronchopneumonia the entire lobe is not involved. Rather you get patchy involvement. See this reddish specks, this reddish spots, these are the involved area, versus the pinkish ones. These pinkish ones are the uninvolved portion of the lobe. Lobar pneumonia te kintu you don't get this. The entire lobe is affected, whereas here the entire lobe is not affected. You get patchy involvement. So if you compare these two pictures, I think it becomes much easier for you. Will you be able to explain? Anana, will you be able to explain? Okay, you need not explain it to me. You explain it to yourself during exams, and you explain to the examiner. That will be perfect. You need not explain it to me. But when I am the examiner, you have to explain it to me, not now. Okay. This is lobar pneumonia. This is lobar pneumonia. This is the normal lung. This is the involved lobe. This is the normal lobe, uninvolved portion. This is the involved portion. Versus bronchopneumonia. See these arrows. This is these arrowheads. These yellowish ones are the involved zone, and these brownish ones are the uninvolved portions. Okay, so that is bronchopneumonia. Presentation. This is a schematic representation, right? See, diffuse involvement of all the alveoli. Diffuse involvement of the alveoli. Yes or no? Over here, involved alveoli, uninvolved alveoli. The alveoli are full of exudates, neutrophils and all fluids, whereas here all the alveoli are involved. So this is lobar pneumonia, diffuse involvement. This is bronchopneumonia, and this is the involved alveoli. These are the uninvolved alveoli. So that is patchy involvement. Whereas the third one is interstitial pneumonia, which I just told you a few minutes back. In interstitial pneumonia, the alveoli are not involved. Rather, you get the neutrophils or the neutrophilic infiltrates into the what? Those are the interstitial tissue. You get the neutrophilic infiltrates into the interstitial tissue. So remember, lobar pneumonia means involvement of the entire lobe. Bronchopneumonia, the entire lobe is not involved, it's patchy involvement. Some of the alveoli are involved, whereas the others are not involved. And number 3 is interstitial pneumonia, where the alveoli are not involved at all, and as the name suggests, interstitial. So you get neutrophilic infiltrates in the interstitial tissue. Okay, and we will be concentrating now on the lobar pneumonia. There are various stages. So we come to the, before coming to the look into the picture. First and foremost thing, মুখে thermometer দিয়েছে কখন দেয়? Fever. Huh? What? Pyrexia. তাহলে কি বলবে? Piloerection. Good. Piloerection কখন হয়? Fever with chills. Piloerection, good. That is piloerection. কিন্তু piloerection টা কখন হয়? Chills. Fever with chills and rigors. What is this? Rusty sputum. Right? সব কটা organism-এ দেখিয়েছি কারা কারা, especially Klebsiella, which produces sputum. Rusty. কেন rusty? Why rusty? Because it can be blood tinged. Sometimes hemoptysis hota pare. Means you're coughing blood out. And what is the last picture? What is this? Buke batha, don't say heart attack, don't say myocardial infarction. What is it? Yes, go ahead. Pleuritic what? Why you know it? Go ahead, tell me. Pleuritic what? Pleuritic rub. Now, Baba, pleuritic chest pain. Pleuritic chest pain. If the exudates from the lungs involve the pleura, you can have those pleuritic chest pain. What are the clinical features? You shouldn't forget it. Pneumonia is a very common thing and you shouldn't forget it. Fever with chills and rigors, rusty sputum, sometimes there can be hemoptysis, okay, and if the pleura is involved, if the infection spreads up to the pleura, the patients can experience pleuritic chest pain. Okay, now coming to the why I'm telling you, before explaining the morphology, why I'm telling you the clinical features is the one, the patient will never come and say, I have maybe I have pneumonia or something, but first and foremost thing is, tomake clinical features to the first day. Patient will come with signs and symptoms. Based on those signs and symptoms, you have to come to your diagnosis. Okay, so first and foremost thing is, clinical features must be known to you before you get into the details of pneumonia. So that is the reason why I have explained the clinical features earlier, before I go into the stages. Okay. So the lobar pneumonia can be divided into 4 stages. The lobar pneumonia can be divided into 4 stages. Stage of congestion. Stage of congestion which lasts for 12 to 24 hours. That's when the person starts to develop these clinical features. Stage of congestion. Number 2 is stage of red hepatization. Stage of red hepatization lasts for 2 to 4 days. Stage of red hepatization lasts for 2 to 4 days. For the next 4 days, you have the third stage, that is called stage of grey hepatization. Stage of grey hepatization. And the final one is takes about 8 to 10 days, which is what? Stage of resolution. Stage of resolution. And there is another stage, it's not always present, organization or cornification. I'll just explain you a little. Let me but finish all these stages individually. So there are 4 stages: stage of congestion, stage of red hepatization, stage of grey hepatization, and stage of resolution. And on the right hand side, you're going to get for how long they last, the period. Okay. So coming to এটা battery change করতে হবে মমিতা, battery change করতে হবে, পুরো একেবারে কাজই করছে না। So stage of congestion. Congestion টা কিভাবে হয়? The organism reaches the alveoli of the lung and causes all the havoc. So what happens in congestion? Congestion maneta ki? The lung is heavy, edematous and red. The lung is heavy, edematous and red. Keno? Huh? Blood circulation bere jache. Not exactly blood circulation. See, once the organism reaches the alveoli, what it causes? It will cause inflammation. It will cause inflammation. So the alveoli will be filled with পরে আসছে neutrophil of congestion অতটা থাকে না, but it will be full of exudates. The lung will be full of exudates. The capillaries will be congested and they will become more leaky. So the fluid comes out of the capillaries. That is because the etiology is infectious, we call it an exudate, not a transudate. We call it an exudate. So and this is the reason why the lung becomes heavy. This is the reason why the lung becomes heavy. Okay. The capillaries are congested and the capillaries will ooze those plasma protein out into the protein rich fluid into the alveolar spaces, okay, resulting in congestion. So during this phase you won't have too many neutrophils, but if you do an examination of this exudate, you'll get plenty of bacteria. The causative organism. Okay. So this is the reason why you have a lung which is heavy and boggy and edematous. Okay. Because the alveolar capillaries, the lungs, the causative organism will reach the alveolus. The alveolar capillaries will be congested and they will what? There will be outpouring of protein rich fluid into the alveolar spaces, which is full of bacteria but not so many neutrophils, and because of this the lung becomes very heavy and congested and very heavy and edematous, boggy. So this is the stage of congestion. Okay, so you can make out the picture here. What are these? These are not neutrophils but the causative organism, the pneumococcus. These are the congested capillaries. These are all the congested blood vessels, and these congested blood vessels will, what will happen? There will be outpouring of protein rich fluid into the alveolar spaces, into the alveolus, resulting in what? The lung being edematous. So this is basically the stage of congestion, 12 to 24 hours. Tarpore ke asche? Stage of red hepatization. What is hepatization? What is hepatization? Solid ALS. Hepatization কেন বলা হচ্ছে? Because it what? It resembles the constituency or resembles that of a consistency of a liver. Because it resembles the consistency of a liver, it is termed hepatization. Okay. Red কেন বলা হচ্ছে? Because you get plenty of red cells. Red cells and fibrinosuppurative exudates fill the alveolar spaces. Red cells and fibrinosuppurative exudates. See, red cells and fibrinosuppurative exudates. Fibrinosuppurative exudate এবার কি থাকবে এখানে? Plenty of neutrophils. There will be red cells and neutrophils in the alveolar spaces, right? There will be red cells and neutrophils into the alveolar spaces. The exudate jeta chilo, slowly but steadily they start to get resolved. Slowly ebar aste ebar the exudates start to resolve very slowly, but still there is plenty of exudates in the alveoli. Okay, so in red hepatization, the grossly it is brick red in consistency, brick red because of presence of many red blood cells, and solid and airless. It becomes solid and airless. Consistency is that of a liver. Microscopic examination, the alveolar spaces are full of exudates. Means there will be plenty of bacteria. Red cells thakbe, there will be plenty of bacteria and RBC and neutrophils in the alveolar spaces. So if you consider this picture, alveolar spaces are predominantly free, versus here, see, the alveolar spaces are full of exudates containing RBC, bacteria and plenty of polymorphonuclear leukocytes. Grossly কিরকম দেখতে থাকবে? The lobes solid, airless. The consistency is that of a liver. আর red কেন থাকবে? Because of red blood cells. Okay. So this is the picture where you can make out many PMNs. What is PMNs? Polymorphonuclear neutrophils. Okay. Then you get bacteria, congested capillary fibrinous. So compare these pictures and study. It becomes very easy for you. Number 3 is stage of gray hepatization. Acha, hepatization মানে সেই solid and airless রইল. Why gray? Why gray? Why gray? Because the red cells disintegrate. The red cells starts to disintegrate. Okay? Neutrophils এর জায়গায় এবার কে আসবে? This is after 4-5 দিন পরে, তো কে আসবে? The macrophages will come into the picture. So this is stage of gray hepatization. And one more thing, কেন gray হয়? Not only the red cells that disintegrate, but the exudates, they compress on the alveolar capillaries, and it does not, because of that pressure on the capillaries, the blood flow is decreased. The blood flow is decreased, and that is why you get those gray pictures. So ekhane ki hoy? So the blood, deoxygenated blood coming to the lungs are not oxygenated, and the same blood returns to the systemic circulation, and this can result in hypoxemia. Clear? Clear? Deoxygenated blood which should actually come to the lung because of congestion and all, because of the pressure by the exudates on the capillaries, this blood cannot come, or they cannot get oxygenated. So the deoxygenated blood, the same deoxygenated blood returns back to systemic circulation, resulting in hypoxemia. Systemic circulation is hypoxemia, and this can be a cause of death in patients of pneumonia. Mind it. Okay? So alveolar filled with fibrinosuppurative exudates as usual. And this is the point that I have explained. The capillary walls are compressed, and because the capillary walls are compressed, blood cannot come, resulting in gray color of the liver. Clear? And one more, the fatal complication of this is the deoxygenated blood, which should actually get oxygenated in the lung, instead of it getting oxygenated, the same deoxygenated blood returns back to systemic circulation, spreads to various systems, resulting in hypoxemia, which can eventually kill the person. So this is stage of gray hepatization. They contain less blood, and that is the reason why we get this gray color. Okay? And finally, about after 8 to 10 days comes the stage of resolution. The stage of resolution. The exudates undergo resolution. They are being consumed by the alveolar macrophages. They undergo enzymatic digestion, and they undergo resolution. So what is left is a semi-solid granular debris. A semi-solid granular debris is produced. Semi-solid granular debris is produced. So last stage eta ki bolechilam? There is a stage of organization which can happen. The stage of organization can happen in unresolved cases. The stage of organization can happen in unresolved cases where the exudates, they are either surrounded by granulation tissue or undergo fibrosis and can cause lung impairment. So that is called organization. The semi-solid debris which should get resolved, instead of it getting resolved, are surrounded by granulation tissue, and they can undergo fibrosis, resulting in organization or kernification of the lobes of the lung. Alright? So this is lobular bronchopneumonia. I am not getting into the details. You should know those 4 stages. Mathay ar nebe na, just go through it once. There is a difference between bronchopneumonia and lobar pneumonia. It will not be asked. The basic difference from us jeta jante hobe, lobar pneumonia means the entire lobe is involved, whereas bronchopneumonia, it's patchy involvement. That is the most important thing. So now what is important is complications. One is pleuritis. Pleuritis ki kore hote pare? If the inflammation spreads into the pleura, resulting in pleuritic pain, that is pleuritis. Lung abscess hote pare, suppurative destruction of the lung parenchyma, suppurative necrotic destruction of the lung parenchyma. Number 3 is empyema. Empyema I have explained, localized collection of pus, and number 4 bacterial dissemination কি করে হয় via hematogenous route predominantly and the outcome can be deadly in such cases কিসে সবচেয়ে commonly হয় Pseudomonas aeruginosa it has a propensity to invade the blood vessels. So these are the various complications which you must remember. Involvement of the pleura resulting in pleuritis, lung abscess, empyema, and dissemination of the bacteria to distant sites, predominantly via hematogenous route. Okay? Out of this two, which is bronchopneumonia and which is lobar pneumonia? 50 to 80% sensitivity. Radiography is the gold standard. Which is bronchopneumonia, which is lobar pneumonia, and why? Okay, left hand side, right hand side. Now tell me. Lobar pneumonia, right hand side is? Cano. Patchy involvement. Good. Taught something. Glad. So, left hand side is bronchopneumonia, is lobar pneumonia because there's diffuse involvement, whereas say the consolidation is diffuse, whereas ekhane dekhte paccho, see these are all the patchy involvement, right? So this is lobar pneumonia on the left, bronchopneumonia is on the right. So radiography is the gold standard with 50 to 80% sensitivity. Number 3, sputum examination. This is purely microbiology, right? Gram stain korte hobe and you get those lancet shaped diplococci, right? And finally blood culture. Blood culture keno korbo amra? So specific identification of the organism and antibiotic sensitivity. Come, I'm not explaining this too much. These 3 are for lab diagnosis. Lab diagnosis pneumonia kintu ei jinish gulo predominantly belongs to microbiology. Okay, and they will be explaining you far better than I can. All right, so this finishes your topic on pneumonia.